those cells continues, then it becomes chronic inflammation. Now, sometimes because of anxiety, we will take our forefinger and rub over our thumb nail bed. That's what this person did. The inflammatory process set up. They couldn't stop doing it, and now they have this little calcified area on their thumb because of chronic inflammation. They were chronically irritating that area. So collagen formed around the white blood cells that went to that area because it was inflamed, and it calcified. If we broke open that area, it would just be liquid inside because the cells have liquefied. But that is a granuloma. It's because of chronic irritation to an area. Let's talk about wound healing. Now, if you go in for surgery, let's say you're going to have, okay, even if you go in for laparoscopic surgery now, we're just gonna do a little puncture wounds, put a little camera in, do a little robotic surgery. Will you have the inflammatory process? Yes, because cells have been damaged. I have to put this scope in through an opening I'm making in your belly. It's not supposed to be there. You're going to have the inflammatory process. Let's say I have to do surgery, but I have to actually make an incision. Are you going to have inflammation around that incision? Yes. So when we get a little bit further, I'm going to tell you what to tell patients to look for. Now, all wounds hopefully will heal. So the first thing that happens is that little macrophage, that little green guy, the little white blood cell, goes and cleans up all the dead cells and all the pathogens that might get in there. Your blood vessels then return to normal. They're not going to keep those little slits open because you've got to stop letting fluid leak out of those blood vessels. They're going to go back to normal, and your cells that can regenerate will regenerate. If the cells cannot regenerate, you're going to have scar tissue formation. So you have to monitor your patients for things that can cause their wounds not to heal properly. If they have an infection, their wound is not going to heal properly. If it's a very large wound, we may not be able to suture it. If they have bled into the area and there's a hematoma, a collection of blood in that area, they cannot heal properly. And if they're not getting adequate nutrition, they don't have the nutrition to create new cells to heal. So when you change your patient's dressing, you're going to, this is how I've seen nurses change dressings into the trash can. Wait, look at it. You have to look at what's on that dressing because you have to chart it, right? If it's serous, it's just watery, it's just plasma. It may be a very pale yellow. If it's purulent, that word just says it all, right? It's pus. Okay, now it's going to be this opaque yuck on there. That's a very scientific term. Okay? Yuck. Don't chart yuck, but you know what pus looks like. If it's serosanguinous, it's going to be pink tinged. It's plasma, which is very pale yellow, and a little bit of blood. So you have to use those terms when you chart. You have to, how much was the dressing saturated? Was there a quarter size area? What did that dressing look like? Now, all surgeons want their wounds to heal by primary or first intention. They suture the wound. They want that area to heal. They don't want it to become infected. And this is what you will see with most surgical wounds. They pull the edge of that wound together. In about a month, that area will be fully healed. They don't have an infection. They have good oxygen to the area. They have good nutrition. The wounds are close together. This is what we want. Healing by secondary intention happens if we cannot suture the wound, or if it's a very large wound. Sometimes it's infected and we have to leave the wound open. We have to irrigate it. So you can see here, that is a wound that's going to heal by secondary intention, not sutured together. It takes a very long time for this wound to heal. We want this wound to heal from the bottom up. One of the things you're going to do is you're going to keep measuring this wound. If you do community health nursing, you may be called to go out to a patient's home to change a dressing. They're healing by secondary intention. You have to measure that wound. We want to see, hopefully, that wound is getting smaller. Scar tissue, when it's new, is pink. As time goes on, that inflammatory process goes away and the scar tissue is white. Now, all that scar tissue does is hold you together. It's important. But you're not going to have melanin in that scar tissue. Melanin is what gives our skin its color. So that scar is going to be white. You're not going to have hair follicles in there. You're not going to have sweat glands in there. It's just holding you together. Keloids happen when too much collagen builds up in that scar. You can see this person had their ear pierced. There's a large round area. It's a keloid. It's just too much collagen, too much scar tissue. Now that can be surgically removed, but it's going to happen again. This has a genetic component to it. Some people are just prone to developing these keloids. Now you want to make sure that your patient has good nutrition or their wounds will not heal. Even though you are physically not bringing a tray to a patient and putting it down. You are physically not picking that tray up and putting it in the cart to go back down to the kitchen. It is your responsibility to know how much food that patient consumed. Maybe we need to give them a supplement. Because if they're not eating, they're not going to have good nutrition, that wound's not going to heal. We know we need oxygen. We know we need adequate circulation. So your patients who have congestive heart failure, their heart is not pumping well. They may have poor wound healing. Our patients who have diabetes may have poor wound healing. Why? Because their blood vessels have been damaged from years of uncontrolled diabetes. They're not getting oxygen to the area. We need a highly functioning immune system so we don't get infected. Corticosteroids, which we'll talk about in a couple of weeks. Corticosteroids tell your immune system not to function at its optimum. So you can have poor wound healing because you can get an infection, just like with immunosuppressants. Contamination. You're going to see nurses take shortcuts. They're not going to follow sterile technique. The wound can become contaminated. surgically inserted devices like a hip replacement, that area can become infected. They have to take out that hardware. Obesity, because we're not getting up and moving around. We're not getting well oxygenated. And age, because our healing process slows down as we age. Now we have some complications that you have to monitor for. Dehiscence, the suture line ruptures, and evisceration, the organs actually protrude from that suture line. I was doing community health nursing and I got a call that I was going to go, it was a Saturday, and it was the end of my shift, and the supervisor called and said, you're picking up a new patient, Mrs. So-and-so, she's just been released from the hospital, but you can go admit her tomorrow. And something said to me, they will go now. So I went to see her, and this was an 83-year-old, very lovely lady with her husband, and she said, yes, I had some abdominal surgery, and they let me go home today. So I'm doing her vitals and blah, blah, blah. And I said, well, let me just take a peek at this wound. Okay, sweetie. And she lifts up her nightgown, and there's her bowel on top of her belly. And I said, oh, did they put a dressing on you before you left? Oh no, the nurse just took it off, told me I'd be fine. So I put on sterile gloves, I got my sterile dressing, I put my sterile saline on it. And she said, is it okay? I said, oh yes, it's fine. And I just covered this bowel to keep it moist, and I called the surgeon. And the surgeon is screeching at me. Not even screaming, it's a screech. My wounds never dehiss. I'm holding the phone out here. And I said, well, this one did. No, you're not looking at it correctly. How can you not tell when the suture line goes? I said, okay, thank you very much, doctor. Now, that was not what I wanted to tell him. So I looked at the husband and I said, everything is fine. They're just going to take a little peek at this. So we're going to take her back to the hospital. Okay, honey. Now, the doctor actually said things I cannot repeat here and did not want this patient sent back to the, I don't care what he said. Okay? Called 911. I said, oh, it'll just be easier than you getting her in the car. And she was back in the hospital for 2 weeks. All right, the takeaway point here is a couple of things. I don't care how skilled the surgeon is, wounds can break apart. I don't care if a doctor yells at you or a nurse yells at you, you do what you know is right. Have you ever been yelled at by anybody in your life? Did you survive it? Now, next time I saw him in the hospital, I said, hello, Dr. So-and-so. So your dog will say, hey, I was right and you were wrong. No, you can't do that. If you're thinking it, don't do it. Okay. Stricture. Now, sometimes scar tissue will grow around a tubular structure, like a common bile duct, and it will compress it, it will shrink it. A fistula is when we have an opening between two structures where there should not be an opening. And adhesions are scar tissue that stick adjacent structures together. Because scar tissue forms, you have intestinal surgery, scar tissue will form, and it can adhere to the peritoneal membrane. So adhesions can occur with any surgery. Pain. Pain tells us that something is wrong. Okay? So it protects you. Now, if you have pain, and we do not control your pain to a manageable level for you, your immune system function will start to decline. You will become very anxious. You may become very demanding. You begin to lose faith in the healthcare system. Your blood, your platelets, will start to stick together and form clots. I want you all to repeat after me. Pain is what the patient says it is. Come on.
Pain is what the patient said it is.
When they say they have it.
When they say they have it.
To the degree they have it.
To the degree they have it.
Okay. Thank you. Remember that? On your patient. Think about that paper cut we talked about. I'm sure, maybe one of these people, I'm sure you know people who, when they get a paper cut, want to put their entire arm in a sling. And this goes on for 20 minutes. And you're thinking, oh, for goodness sakes, it's a paper cut. Other people can be riding their bicycle, hit a pothole, fall off, scrape all the skin off both legs, and they say, oh, well, I guess had a little, right? I don't care what kind of person you are, whether you're the hand in the sling because I have a paper cut or the other. It doesn't matter when you're taking care of a patient. What matters is their perception. I do a nurse residency program at Yale, and one of the new graduates who worked in labor and birth, who was sharing stories about what had happened in the past month, and we were talking about pain. And she said, oh yeah, I had this woman come in, this was her fourth baby. And I just said to her, look, honey, don't you ask me for any pain medication. You know what's coming, just get on with it. And I went, what? She said, well, for goodness sakes, it was her fourth kid. She knew what was coming. Could have heard a pin drop. Guess who was not employed the next day? Right? It doesn't matter what your feelings about pain is. It only matters what the patient's perception is. So acute pain is you walk out of here and you stub your toe. That hurts. It happens in a hurry. And then hopefully it will decrease. You have surgery. You wake up from anesthesia. If the lidocaine has worn off, you have acute pain. Now, can you always tell by looking at a person if they have pain? No. In some cultures, it is disrespectful to the healthcare professionals to show pain, and they will not, because they should not burden you with their pain. So you cannot tell by looking at something. Sometimes we can tell by vital signs if a patient is in pain. Vital signs may change. Blood pressure goes up because blood vessels constrict. Heart rate goes up. Respiratory rate goes up. They guard. Person with peritonitis is going to guard that it don't touch my belly. Sometimes the only way you know a patient is in pain if they vomit. I had a patient with pancreatitis. She was in a culture where it was inappropriate to show pain. We had a nasogastric tube down to rest her belly, and her husband came out and said, my wife is in pain. Now we were asking like every 20 minutes, do we have pain medication? I said, well, we've been asking. He said, I know, but she cannot tell you she has pain. She's starting to vomit around her NG tube. So if you have someone from a different culture, ask, what is the pain expression like? Because we didn't know before that. So then we started medicating her and she was fine. Chronic pain, if you have back pain, maybe chronic back pain, fibromyalgia, maybe chronic muscle pain, chronic pain anywhere, we generally don't see any change in vital signs because it's over a long period of time. But your patient will be tired because they can't sleep at night. They're going to be irritable because their pain has not been relieved. They may be depressed. I can't take this anymore. Some people will eat, some people will not eat. So, pain is the fifth vital sign. You always have to ask your patient about pain. Now, sometimes people don't use that term pain. They say, are you having pain or discomfort? Because to some people, pain is a really sharp pain. Maybe that's not what they have. Oh yeah, my belly hurts. It doesn't feel good. All right? So use pain and discomfort. We've got all kinds of pain scales. You're going to learn about that in health assessment. We have facial ones where the little face is smiling and at the end it's tearing. What do you think? Which gender do you think is reluctant to use that faces rating scale? Men or women? Generally, men don't like to use it. Why? Because it shows tears. Our society says, unfortunately, and I hope this will change, men aren't supposed to tell you they have pain. They're tough. Your foot gets run over by a car, just suck it up. You're amazing. A woman gets a paper cut, we put her on a pillow, give her ice cream all day long. Okay? We have the same nerve endings, people, so rating 1 to 10, people will generally use that. Now, you cannot adequately medicate, know if your medication is helping relieve pain, we're going to talk about meds next week, unless the patient rates it somehow. You can't tell by looking at someone whether that morphine that you gave them is helping to relieve their pain. You can never bring pain down from a 10 to a 0. You ask your patient, what is an acceptable level of pain for you? Some people will say, I'd like it reduced to a 4. Some people will say, oh, a 6 is fine. So you have to find out. So you ask them before and after you medicate them. This is in your book. If you remember old CART, you will remember the questions you're supposed to ask concerning pain. When did it start? Where is it? How long have you had the pain? What is it like? Is it stabbing? Is it colicky? It comes in spasms? Is it dull? Is it squeezing? What's your pain like? What started your pain? Well, patient answered, I coughed without the support of my pillow. What will relieve your pain? You know, last time I had morphine, my pain went away. I could get up, I could walk, I could cough, I could deep breathe. Do you use any treatment? If this is somebody coming in and they have arthritis pain, what do you do at home for your arthritis? Whatever it is, so you ask these questions. Now, your initial pain response, when something harms your body and you have pain, you will release endorphins. Endorphins help you manage the pain until you can get someplace safe and take medication or whatever. Think about when you were little. If you fell down and scraped your knee, many of you would run all the way home not shed a tear, and the minute you got in the house, and whoever it was that was taking care of you, they were, why? Because when you first fell, it was scary. I fell, I hurt myself, I'm not at home. Those endorphins were released. You ran home, and the minute you felt safe, then your brain said, okay, now you can perceive that you have pain, because somebody's here to help you. Now, your nervous system partly determines your perception of pain. The pain signal has to go from the area of injury up to your brain to be interpreted, and then you take some action. It's also cultural. In some cultures, it is appropriate to show a lot of pain. You're encouraged to verbalize when you have pain. In other cultures, it is not, so keep that in mind. Some of you grew up in households where if you got hurt, you scraped your knee, okay, it got washed off, and then go back out and play. And others, same scrape, got washed off, put on a pillow in front of the TV, have some ice cream, everybody fussed over you. That's learned. Some people have a very strong emotional response to pain. Let's face it, pain hurts. But how your patients let you know and respond to it has a lot of different components. That's why pain is what they say it is, when they say they have it, to the degree they say they have it. So, why can you have pain? Well, your skin can be injured. Your skin is a very large organ. It can be injured. Somatic pain, if you see that on your chart, that comes from pain receptors in bones, in blood vessels, in nerves. Patients will say this is it's a dull pain, it's not a sharp pain. Visceral pain is your organs. Actually, something's going on with your organs that's causing pain. And then we have referred pain. There's a very good explanation of referred pain in your book. Phantom pain. Your patients have an amputation. Their foot has been amputated. They may say, my foot hurts. You don't have a foot. I know, but it hurts. Why? Because the pathways in the brain still think that you have a foot. There was a doctor in San Francisco who worked a lot with patients who had phantom pain from an amputation. And one of his patients, this was an elective amputation because of contractures. His hand had been closed and his nails were digging into his hand. They couldn't open his hand. The pain was so severe. They were never going to be able to do anything to help the arm. He said, I will have the amputation. After his hand was amputated, he still had the pain. And so this doctor, genius, took a box, put a mirror in it. Now this hand is gone. He said, close your right hand and put it in the box. The patient did. And when the patient did that, he saw a right and a left hand because of the mirror. He said, slowly open your hand. The patient did. His brain saw the left hand open. The pain went away. Because now the brain said, oh, the hand is open.
So what we as nurses would do something like that when patients have the phantom pain. So
You can try it. Yeah, we're using this a lot now with patients who do receive phantom pain. Phantom pain for most patients eventually will go away because the brain will eventually realize there is no hand, there is no leg, whatever it is. But in the interim, they have been using this and it works.
So, would you say phantom limb pain is more a neurologic thing more than physical?
It's
pain?
not a psychological thing. It's because the nerves have been cut when the amputation is there, those nerves are still irritated. So they're still perceiving pain. I would say it was both, because when you look and you see you don't have a hand, your brain should be able to say there is no hand, there should be no pain, but the nerves at the end where the amputation occurred are still irritated.
And how long would that last?
It depends on the person. Depends on the person. Okay, so if your patient has colicky pain, and we usually have this in the gut region, pain will come and pain will go. That's how you describe it. Patient states they have colic, comes in spasms. Hyperalgesia is a very exaggerated response to an injury, like that paper cut, where I'm gonna jump around and cry that I have pain for 2 hours after a paper cut. I'm not saying it's not real, I'm saying it's an exaggerated response related to the amount of tissue injury. Allodynia is when a patient has pain from something they should not have pain from. So you go in and you just walk by a patient and it causes a little breeze on their arm, and they grab their arm and say, oh, that's really painful. It's because of the way their nerves are functioning. So just walking by a patient causing a breeze should not cause pain. A patient with allodynia does have pain. Now there's a gate control theory of pain that changed how we think about pain and how we medicate patients for pain. So there's some signal that is saying, okay, this area has been injured. Right? So it goes from your paper cut, goes from your hand up to your spinal cord. Now there are interneurons in your spinal cord that can either say, we're going to amplify this pain sensation, or we're going to make it seem less. And this is all automatic. Goes up to the brain interprets it and sends a signal back down. Things like massage, like acupressure, irritable substances like icy hot or capsaicin, transcutaneous electrical nerve stimulation. We give you little pulses of electricity that you don't really feel, but it stimulates the nerves. It's interrupting that gate theory of pain. There's some other signal that's sent to the brain instead of the pain signal. And that's why these types of therapy actually work. You're interrupting that signal from going to whatever area is injured through the spinal cord up to the brain and back down. There's something else that's going up there instead. Oh, it's massage. Massage feels good. Or it's this electrical stimulation of nerves. Or this irritant feeling, like from icy hot. If you've ever used icy hot, it does feel like it's warm. So it sets up a little inflammatory response. The brain interprets that instead of pain. Now, remember we talked about endorphins and morphine-like substance, opiate-like substance? Hypnosis, guided imagery, makes us release those endorphins. You're going to see a lot of that used when you go to labor and birth. When we get through the birth process without opioids, we're going to use guided imagery. You're releasing your own natural opioids. So nociceptor receptors are little nerves that transmit the sensation of pain. They're all over your body. So here you see someone, he's holding his arm over a flame. The flame is hot. Okay, so the tissue on the underside, on the top of his hand, gets that signal, uh-oh, this is hot. Here is our friend, histamine released again. Mast cells have gotten the message to break apart because there's tissue injury from that heat. So we release histamine, which causes blood vessels to dilate, arachidonic acid, which converts to prostaglandins, which can then influence how quickly that pain sensation is transmitted to the brain. Substance P is like putting gasoline on a fire. It makes that normal nerve impulse speed ahead and get up to the brain much more quickly. So we get that signal that goes to the central nervous system and then up to the brain saying, this is hot. So what do? We remove our hand. That's how pain can be helpful. It warns us of danger. Now, for nociceptor receptors, they've been aggravated and the pain sensation is felt. We can give nonsteroidal anti-inflammatory drugs that we'll talk about next week, and we can give opioids or narcotics. So once these nociceptor areas are stimulated and create pain, we have alpha fibers and C fibers in the spinal cord. And we can have different pain sensations. You can have that sharp pain. Some patients will have a dull pain. You don't have to memorize which does which, but it's just that's the difference in our perception of pain. It depends on which nerve fibers have been stimulated. There are dermatomes and myotomes. When you go to the doctor and say, I'm getting pain down my left leg, the doctor, nurse practitioner, is going to test that left leg. Where is the pain? What does it feel like? And they can pinpoint, oh, well, this is because this particular nerve has been stimulated. This muscle group has been stimulated. So again, you're not going to memorize all of this. But if you work in a pain clinic and you are working with a nurse practitioner or physician who's testing a patient, they're looking at which areas of the body does the patient perceive they have pain, and then they can figure out which nerve root has been stimulated, depending upon where the pain is and the muscle group that's affected. Neuropathic pain is different than nociceptor pain. Nociceptor pain is caused by aggravation of any of these little nociceptor receptors all over our body. Neuropathic pain is actually caused by damage to the nerves. Diabetic neuropathy, which we'll talk about next semester, nerves can be damaged by years of uncontrolled high blood glucose. We can have nervous system disorders that cause aggravation to certain nerve groups, and it will result in chronic pain. So what we usually see, like with our diabetic neuropathy, is the nerve endings in the feet are going to be affected first, and then it moves up. The nerve endings in the hands, and then it moves up the shoulders. Now, for neuropathic pain, again, caused by direct stimulation of nerves, we think one of the reasons this occurs is because of the way sodium moves in and out of channels in the nerve itself. And so some of the medications that we're going to use that you'll learn about next week help to slow down this exchange of sodium, potassium inside and outside of the cell. They block the receptors so sodium doesn't go in and cause this reaction in the nerve. A lot of these medications are actually antidepressants. So when you have a patient on an antidepressant, they may be using that antidepressant to control chronic nerve pain, like diabetic neuropathy, or they may be using it to help alleviate depression. Substance P is a substance, again, that speeds the transmission of that nerve impulse up to the brain so it can be interpreted as, yes, I have pain. Now, one of the pain theories is that these nociceptors release too much of this substance P, the prostaglandins release too much of this substance P, and so the cells around the injured area also become sensitized and they create that pain sensation. So we can give things like lidocaine, which is an anesthetic to calm down these nerves. Capsaicin. Capsaicin is what you see in a lot of the arthritis creams, like Aspercreme. So we'll talk about the specific meds some next week and some a little bit later. But the takeaway point is here, not everyone needs a narcotic for pain relief. Depends on where the pain is and what's causing the pain. Okay, do you think you're going to survive? Yeah. Good. I have one left. I will post a study guide. I haven't finished the test yet. So your study guide for this week will be up either tonight or tomorrow.